which is not a large group, I have to say, but I know Venny's there, so welcome, Venny, and Peter, who is working with us at Mantara. I'm hoping a few more people are going to join, otherwise it could be a personal webinar for you, Venny, and we can catch up in due course. But hopefully a few more will come in. But as I said, if one person gains some knowledge from this and starts to think more about pharmacogenomics, then that's one more than would have done so before this talk. So anyway, welcome. I'm going to share my screen and we will start to get cracking. So I'm going to be talking around personalized medicine and specifically how pharmacogenomics or PGX can and is starting to transform patient care, and with specific reference to Clopidogrel as an example, as the first mainstream drug that NICE have issued guidance for in July of last year. Just to clarify about myself, I am the founder, chairman, and now medical director, and CEO, and probably the cleaner and the bottle washer and anything else that comes to mind. We're a small company, but a very important group of people that are working very hard to make this successful. The Mantara Health Limited Company has launched the first CE and UKC marked pharmacogenomic panel test, fully registered with the MHRA. And I would just like to confirm that Mantara Health nor myself are receiving any remuneration for today's presentation. Let's go to the next slide. Here we go. So just a bit about me. I am a consultant dermatologist. That was my first love as a registrar. It's what grabbed me, and I trained to become a dermatologist in Newcastle upon Tyne with some training in Cardiff before that. I set up a private clinic about 22 years ago now with my wife in Canterbury. That was sold about 7 years ago to an equity company and was bought just before Christmas by Bupa. And I'm now Chief Medical Officer for the Dermatology Partnership, which is the largest private group of clinics in the country with consultant dermatologists. I'm also the co-founder and chairman and medical director of the Xroid group of companies and founder, chairman and CEO of Mantara Health, as I just said. So therapeutics has always been a passion for me, and when I was an NHS consultant, which I stopped being 11 years ago now, just over, I sat on the Drugs and Therapeutics Committee for most of that period of time. I've always been interested in how we can prescribe better and more safely and to introduce new drugs when appropriate, and hence my attraction to that particular body. Sustainability is also a passion of mine, and pharmacogenomics obviously feeds nicely into that agenda because of significantly reducing drug waste as just the tip of the iceberg. That 90% of medications only work as intended in 30 to 50% of those patients we prescribe to is really the starting point, and genetics is going to give us some big changes as we move forward. So the challenges in prescription medicine are manyfold. When we have a patient in front of us, we've got to take all aspects of that patient that we know of them in terms of their general health, their other health conditions, what other medications they might be on. We have to realize that there is a prevalence of non-response in the medications that we may prescribe for a disease process. That in turn will have an economic and emotional toll on the patients that we're prescribing to. Obviously, the traditional way of prescribing is trial and error. So we try it. If it works, great. If it doesn't, it may be we have to reduce the dose or increase the dose, or if they're having significant side effects, stop it altogether. In terms of the long-term consequences, these are obviously significantly impacted by what we do for our patients, and we will be seeing them on a regular basis to adjust things accordingly. And it is going to impact on patients' quality of life in no uncertain terms, in terms of the disease itself, but also potentially the medications we're prescribing in terms of, do we get control of the problem? Do they get side effects? Do we have to fiddle about? Does it take a long time to achieve these aims for the patient? And ultimately, there are the genetic factors related to drug metabolism that are really important for us to now get a handle on, understand, and start to engage with in terms of looking after our patients, because it is something that's really important. So one size doesn't fit all. We've heard that many times, but if you look at the data, look at the literature, 90% of drugs are effective in only 30 to 50% of patients. That was a paper published in Nature. 89% of patients over the age of 70 are taking at least one drug with a known genetic interaction. That is a lot of people. 46% of commonly prescribed medications are ineffective or less effective for 46% of patients with depression, arthritis, diabetes, and asthma. And recent updates from the Progress study done in Manchester has shown that 28% of patients who are on 4 types of medication, Clopidogrel specifically, and the subject of today's talk, the proton pump inhibitors, antidepressants, and the other one that I've just forgotten, and everything else is blocking out, so I can't even see it. I'll see if I can get that out of the way. No, I can't. Yes, I can. Oh, sorry, I've just stopped sharing, I think. Let's share that again, and I will come back to where I was, which hopefully is there. Yeah, 28% proton pump inhibitors, that was it. So a significant number of patients are changing their prescriptions when they've had preemptive pharmacogenomics to understand what their medications are and what suits them. So 28% are changing them with these common medications. So introducing pharmacogenomics. So imagine a healthcare system where medical decisions are not based on one-size-fits-all standards, but where the needs of each and every patient can be considered based on their unique genetics, their lifestyle, their environment, and even socioeconomic factors. As doctors, we've all been there, watching patients struggle because the first-line treatment has not worked as expected. Pharmacogenomics, or PGX, changes this narrative. It allows us to predict how well a medication may work for a patient based on their unique genetic makeup, so-called personalised medicine. And that is now accessible to every patient in this country in theory, albeit it's only available privately at the moment, except in certain situations on the NHS where high-cost cancer drugs are being looked at from a pharmacogenomic perspective before prescribing, and some HIV drugs similarly. How many patients experience unwanted side effects from a medication, some of which, at the worst end of the spectrum, can be life-threatening? We know from a study done in Liverpool by Professor Per Mohammed and team that up to 16.7% of acute admissions that come in through the accident and emergency departments are secondary to severe adverse drug reactions. Considering that most adverse drug reactions are not severe and are managed in an outpatient setting, will give you some perspective as the cost that this problem is generating. The cost relevant to the acute admissions in the study was estimated to be £2.21 billion for the NHS in a single year, and increasing. So you can see from that, it is going to be massive in terms of the potential savings that implementing pharmacogenomics is going to make across the healthcare economy and the wider economy. Being able to take the guesswork out of prescribing and using the right drug at the right dose first time is the holy grail for prescribing medicine. And it is here, and it is going to change prescription medicine forever, starting now, or now as soon as you can get your head around it and implement it and find out how to do it now. So the significant cost savings that can be achieved. Well, the obvious one is drug waste significantly reduced. You know, if half the medications or more are not working for patients, don't waste them. They can be given to patients they do work in, but don't give them to patients they're destined not to work in. It makes sense. We've got the tool to now achieve that goal. It will potentially free up a lot of appointments, wasting doctors' time, getting patients back again and again, filling with their medication, only destined to stop it and then try another one because it hasn't worked or has caused side effects. It's going to reduce waiting times on the NHS and potentially privately as well. And, you know, wasting time is not good for patients, it's not good for doctors, it's not good for the system. And most importantly, patients will be healthier with improved quality of life, with their disease being managed using the right medications at the right time and at the right dose for them. This is the promise that pharmacogenomics provides as part of precision medicine. So I looked at it, thought about it, and looked at other people's thoughts as well. And there are currently 3 types of active prescribers out there. I've called them type 1, type 2, type 3, as you would. So type 1, these are the pharmacists, the doctors, the nurses that know about pharmacogenomics, which they appreciate can potentially change outcomes for patients. They've read some studies and have a basic understanding and find it interesting. However, in real life, they are too busy. It's too hard or too new. It's not their job to implement it. Someone else can do it. They chose the status quo over change, and that is probably a large number of the people out in the healthcare world. Then there's type 2. Those are the ones that have not even heard of pharmacogenomics. It's not their fault, as they weren't taught at university. It hasn't crossed their radar of knowledge gathering, probably as they've been too busy trying to keep their day jobs going, keeping their heads above water, managing patients that are coming along one after another after another. No one has handed them the key to the PGX door. And then there's the type 3, those that think about and use this tool in their patients. This group are the movers and the shakers. They're the early adopters, and they appreciate that pharmacogenomics is a game changer for helping guide medication choices for the patients they see. They know that the patient's genetic variants can predict whether a drug might work or not, or may even cause harm. They know that if someone is a poor metabolizer of CYP2D6, that codeine, an important painkiller, won't work for them. They know that variants in the CYP2C19 gene can mean that Clopidogrel will not protect patients from having another stroke. And these bits of information are not interesting trivia, they are life-changing knowledge. At the moment, however, there are only a very few number of type 3 prescribers out there. But the reality is we should all be type 3 prescribers going forwards, and it is now our ethical duty to use this tool for the benefit of our patients and ultimately ourselves. So what does this mean for us here in the UK, in the NHS and private settings? Well, genetics in the broadest sense has, up until now, been seen as a specialist area only practiced by clinical geneticists. But pharmacogenomics is different. As I said, it's our ethical duty to offer this testing to all patients, and it will be used by all prescribers in both community and hospital settings. And in terms of education, it's already part of the pharmacy curriculum. It's not on the medical school curriculum, however. So raising awareness and educating all of us is the challenge and the opportunity. Why? Well, because of the impact pharmacogenomics can have on many of the commonest medications we use every day in our patients. A recent study suggests that having a pharmacogenomic panel test will impact and have an effect on at least 80% of patients over their lifetime. Even 75% of patients over the age of 70, it will impact them. It will reduce adverse drug reactions. It will improve treatment efficacy, safety, and adherence. Another study has looked at the yellow card reports that are sent in for patients that have adverse reactions, and only a proportion of these are reported, of course, but the study showed that 9% of these reports could have been prevented by preemptive pharmacogenomic testing beforehand, which is a very large number of adverse reactions. The impact that prescribing has on the carbon footprint, with the NHS aiming for carbon net zero by 2040, is also significant. Indeed, the pharmaceutical side of the NHS accounts for around 20% of the carbon footprint, so being able to reduce it significantly is going to achieve part of that agenda. The cost savings that can be made are potentially eye-watering and quick to realise too, even within year. Patients will increasingly demand access when they find out about it. And with respect to ethnicity, with diverse population that we have in the UK in particular, a lot of these will now benefit from the implementation of pharmacogenomics, and Clopidogrel is one such example, which I will come on to later. The SPCs within the BNF, etc., contain pharmacogenetic advice already, e.g. for codeine. So it states if a patient is a CYP2D6 poor metabolizer, you shouldn't use codeine. It's written there, but because we haven't had access until now to such testing, it's always been ignored. We need to change that. So with everything that PGX has to offer, why isn't it already being used? Prescribers, including pharmacists, doctors, and nurse prescribers, all need to be aware of and use this amazing tool for the benefit of patients. So why aren't they? Is it a lack of education and awareness? Yeah, there's a lot of lack of education, and there's a huge amount of awareness issue that we need to address moving forward so that patients and healthcare providers together understand the importance of this in terms of patient safety, better prescribing, etc. Is it because it's too expensive? Well, no. The NICE guidance relating to Clopidogrel use stated within it that as long as a test costs less than £1,920, it will be cost saving. So no, it's not expensive. Just by testing that one gene, As long as the testing process is less than that, it is going to save money, and it will save money in year. So we're not looking at a 3-year plan or a 5-year plan for cost savings to be generated. It will happen in year. So why aren't ICBs? Why aren't the NHS introducing this more quickly? Can our hard-pressed NHS healthcare system implement it? No, they can't. That's the reality. And that's one of the stumbling blocks. The genomic hubs that we have do not have the facilities to be able to do widespread pharmacogenomic testing. And that is a blocker on moving things forward. And there's a lot of work trying to work out how this can change so that we can implement it. Is it too hard to do with all the other priorities? Absolutely. The NHS is struggling to keep their head above water, coping with all the things on a day-to-day basis, as we know from watching the news on a regular basis. There are always headlines. It's a challenge, but can we afford not to do it is the question I would ask. It's really important, and it will streamline the activities and allow us to be able to make it easier for the other problems to be solved, or more easily solved, if you can reduce the demand on the service by taking out a whole swathe of patients that are putting their adverse drug reaction issues into A's and E's, etc. And people coming back again and again to see their GPs, wasting time because they're using the wrong drug. If you know what to do, if you know what drug to prescribe in that patient, you're going to make things so much better. Is it because of medical politics and our academics inadvertently slowing progress? Absolutely. I mean, I think it's an absolute travesty that the politics gets in the way of trying to move these sorts of agendas forward. Academics are trying hard, but at the same time, by doing testing and saying they're waiting for results to come out, it's making other people make the decision of, well, we won't do it now. Let's kick the can down the road. Let's wait for the results, which I think is a disaster. I mean, in fact, I think it's a national disaster that pharmacogenomics hasn't been implemented more widely already. It needs people to joined up thinking, have good discussions, work out how to do it. And if it involves the private sector, then absolutely embrace it, because at the end of the day, it's for the benefit of all. Now consider these facts. 8.7 million in the UK were prescribed antidepressants in the year to March. And that's according to the NHS Business Services Authority. 46% of antidepressants do not work as intended in this group of patients, which is, as you can see, a massive drain on resources, wasted medications, ineffective treatment, and added burden of hospital and clinic visits, let alone the effect on the patients themselves, which is huge. 1 in 4 people over the age of 25 will suffer a stroke in their lifetime. There are 1.3 million stroke survivors in the UK, costing around £26 billion per annum. And this is estimated to increase to 75 billion by 2035. We need to be addressing these issues much more stringently, carefully, and pharmacogenomics is going to be a big part of that agenda. So going back, where did this all start? Why have we got variants? And DNA variants are responsible for the drug responses we have. And the origins are really in plants developing ways to defend themselves against mechanical injury and producing chemicals to help them. And the DNA variants in the organisms that were looking to eat those plants developed competence to metabolize some of these chemicals, something called xenobiotica. And this enabled survival of the animals to eat the plants, to generate offspring, and within those offspring to develop inheritance of DNA variants, giving them advantages, part of the Darwinian theory of, survival of the fittest, survival of those with the genetic adaptations that can survive in a tough world. And that is the basis of where our genetic variations come from to give us advantages in our world. So looking at the variations in drug response, the principles of cause and effect. So you can have a gene, and within that gene there can be a variation, and the drug that the patient is given can have one of a number of effects. A single dose, as in the top on the right, can work as intended. For other people, they may need 3 or 4 times the dose that a normal person has because of their drug variant to have a clinical effect. Others may require half the normal dose, and yet others it may have a significant adverse effect, side effects, potentially lethal effects, depending on their particular variant and the drug being chosen. So knowing what your genetic variant is quite important in being able to decide, are you on a normal dose, a higher dose than normal, a lower dose than normal, or avoid it and use something completely different. And in this context, overall, about a third of drugs that we prescribe work as intended and the therapeutic effect is achieved. And in 2/3, you get undesirable effects, which may be a stronger effect, which can be toxic or lethal with adverse drug reactions, or it can have a reduced effect or no effect because they're non-responders. Of the drugs that we use, between 25 and 90% of the variability associated with those drugs is associated with genetic variants. So it's a significant part of this equation. So what do you do then? Well, if a drug response is too strong or toxic and patients are prone to getting adverse drug reactions, you can reduce the dose, or a decision may be for an alternative, better suited medication based on their genetic profile. If a drug response is too weak or they're a non-responder, you can increase the dose, or an alternative decision would be an alternative, better suited medication based on their genetics. So I'm going to move to Clopidogrel, which is the main subject of this talk, to give it as a good example of how pharmacogenomics can be really impactful. In the UK each year, there are about 100,000 strokes. Clopidogrel is what we call an antiplatelet agent. It's an inactive prodrug. In other words, it needs to be metabolized to become active, to have the impact that we want it to have in making our platelets less sticky. And that's the plan with it. And it works brilliantly. It does reduce the risk of further strokes, of death, of myocardial infarctions in patients in whom they have the right variant of gene, so that the Clopidogrel drug is metabolized to the active form, and it has the impact in reducing platelet stickiness and stops thrombosis of blood vessels in various places, obviously important ones being the brain and the heart. And this is all managed through the CYP2C19 enzyme from that drug, from that gene itself. Now, there are a number of variants of this gene, and we know that it will reduce stroke risk. If you've had a stroke or a TIA and you're put on this drug, it reduces it. However, if the drug doesn't work for you, we know from studies that there's a 46% increased risk of having another stroke or heart attack in the time beyond it. In other words, the drug is having no protective effect for that patient at all. And in the UK, from studies that have been done, it does not work as intended in 32% of the UK population. That's about 1 in 3 people. The drug doesn't work. So 1 in 3 people who've been given Clopidogrel to help protect them from having a stroke or other blood clot, it's doing nothing. And from the ethnicity perspective, we also know that British South Asians, it doesn't work in 57%. That's more than half of this higher risk group of patients in terms of risk of having heart attacks and strokes. So it's crazy. We need to know what their status is so that we can prescribe better and more safely. And if the Clopidogrel doesn't work for them, to prescribe an alternative which will help. Looking at this in a diagrammatic form in a bit more detail, Clopidogrel is eaten. It goes into the gut. It is absorbed. 85% of it is deactivated and goes out with your poo, and the 15% is absorbed, goes through the liver, and is metabolized by various enzymes, including the CYP2C19, and this creates the active metabolite. This binds to something called the P2RY12 receptor on platelets, and that in turn affects the fibrinogen receptor. And this is, if you like, the sticky stuff between the platelets that allows them to glue together. And if we can reduce that stickiness, then the likelihood of these platelets clumping and blocking arteries in the ways that happen in terms of a TIA, a stroke or a heart attack, we can reduce the risks of those patients having a further one. NICE guidance came out in July 2024, in which it said that those patients presenting with an ischemic stroke or transient ischemic attack, also called a TIA, should have a genetic test to find out whether they can be treated with a drug that does reduce the risk of further strokes. Since then, obviously, it has not been implemented in the NHS. There are 4 study sites that have been looked at to find out whether or not they can do it easily or not so easily, work out all the good, the bad and the ugly in terms of implementation. And the plan, once the results of that trial are known, are going to be a more widespread take-up by the NHS in theory. It's taking time. We know it works. The evidence is there. Why are we dithering? Why aren't all trusts buying these machines and getting going? Because every day that delays is another patient that could lose their life or be seriously affected by having another stroke, a TIA or an MI. Indeed, Mark Chapman, the NICE Interim Director of Medical Technology and Digital Evaluation, stated, treatment with clopidogrel is effective in preventing further strokes for the majority of people who don't have the gene variant. But until now, doctors have not known who cannot be treated with clopidogrel until after they've had a second stroke or TIA, and that could be too late. If we know what genetic variant they've got, we know whether they are in the 32% that should have an alternative or in the 68% that are okay to take that drug, which is very powerful in effect for that group. So looking at the variants, so the prodrug is taken in its inactive precursor form. It goes into the liver, CYP2C19 amongst others, activates it, and it has its clinical effect. A little genetic tweak in the CYP2C19 gene, and there's a particular variant called the CYP2C19 star 2 variety. This is where an adenine is replaced by the normal, the guanine is replaced by the normal by adenine, and this leads to loss of function of that particular enzyme, and therefore the drug going in is not activated, and therefore you get no clinical effect. These are the group of patients we're trying to identify. And in studies that have been done, if you look at the red line and the green line in this particular graph, the green line shows patients who are taking clopidogrel and are able to metabolize it, so they're getting the protective effect. So it doesn't stop death, acute MIs, or repeat strokes in this patient group, but compared to the red line patients who are non-responders, it significantly has an impact in terms of increased death, acute MI, or repeat strokes. Indeed, studies have been done looking at stroke, and 46% have increased risk of stroke if they're in that particular group. So it's a very powerful tool to make a very, very important difference for patients. And of course, the healthcare economy, because obviously having a stroke costs a lot of money. Indeed, in that NICE paper, it's estimated that the cost of each year of a stroke to be managed is about £50,000. If we can reduce that, that's a lot of savings. Now, there are different types of pharmacogenomic testing. There is panel testing and there is point of care testing. Panel testing tests for multiple genes and for multiple drugs. And point of care testing looks for different variants of the same gene for a single drug. So there is a point of care test for clopidogrel, and that's been trialled in these 4 hospitals in the NHS. There is also a point of care test looking at an antibiotic called gentamicin, which can increase the risk of deafness in 1 in 500 patients or thereabouts that takes it. And that would be profound deafness for the rest of their lives, which would be significantly quality disenhancing. So you can use a point of care test, you get a very quick result, you know whether you can give that drug. If you can give it. If you're in that 1 in 500, give an alternative, and you'll be saving that child from a lifetime of deafness and all of the impacts that's going to have on their life. Panel testing, on the other hand, is not as quick. It's a slower process to turn around. It's looking at multiple genes and multiple drugs. And that is going to take probably 2 weeks at best, 6 to 8 weeks at worst for that result to come back. So if you want a quick answer, that's not the one to get. But if it's a preemptive test and you want information for the future, if it's not an urgent change that's required, then it can be done. At the moment, the Mantara test, it takes about 4 to 6 weeks. On a very bad run, it'll be 8 weeks, depending on logistics and timing of samples arriving at the lab. However, we are looking to work with a UK lab, and by the beginning of July, we should be able to turn tests around within 2 weeks, which is quite exciting. So what is the Mantara pharmacogenomic panel test? What is it? Well, it's a saliva-based test. Patients can order it online. It arrives at their door. They spit into a tube, register it on our website, and send it back in the post. It is then going to result in that being going to the lab. The genes specifically related to drug metabolism only, so just 12 genes, will be extracted, analysed, and based on the variants that we find, you'll be given a specific report to tell you which drugs of the 77 drugs that are commonly prescribed in the UK, based on a paper that was published in the Lancet in 2023, looking at nearly 7,000 patients across Europe, including about 1,000 in the UK. So it's backed by good evidence. The Mantara test, Mantara is the first UKCA marked and CE marked pharmacogenomic provider in the UK. It aligns with the UPGX Prepare study in the Lancet. It is a medical device, class 1, and it fulfills all the regulatory requirements. And there are internal compliances that are also met in the correct way. So you can be sure that it's validated, it's effective, you can rely on the information received from it. And we are certainly in a good position to give actionable advice which can be trusted. The gene drive pharmacogenomic point of care test is an even simpler yet effective process. It's an easy cheek swab this time, similar to what we did during the pandemic when we were taking cheek swabs. It's a cheek swab, and this time we look at comprehensive genetic analysis, specifically looking at the CYP2C19 gene variants. Turnaround times are very quick. From a private point of view, the turnaround time should be within 1 week, and we'll tell you whether you can take the drug or you should have an alternative. Again, Gene Drive is a UKCA marked pharmacogenomic point of care provider in the UK, and Mantara is working with Gene Drive to make this available to private patients in the UK. Again, that should be within the next 2 to 3 weeks. So from July, we should definitely be live, being able to provide this test to patients in the UK who want to find out if their Clopidogrel is actually working with them, or is it doing nothing, in which case an alternative could be considered. As I said earlier, there are over 1 million people in this country who are on Clopidogrel, so there's a lot of potential patients that may want to know that answer, considering that overall 32% of them are on the drug and it's not doing anything. So in summary and conclusion, pharmacogenomics will soon be the new standard of care and will lead to safer prescribing and improved health outcomes. The near future is likely to see a combination of both point of care and panel testing, but in the long run, the logic is that we will all have a pharmacogenomic test when we're babies, and it will become part of our electronic patient record, so that when we need medication at some point in our lives, it will be there as a guide to which prescriptions we should be given and which should be avoided. The evidence is mounting as to both the cost effectiveness of and the cost savings relating to pharmacogenomics, and it will save billions of pounds for the healthcare and wider economies, and that can be achieved very rapidly. The carbon impact of pharmacogenomic guided prescribing and reduced polypharmacy with fewer adverse drug reactions and improved outcomes will be significant, as you've heard from me today. And the challenges are now around education, around raising awareness, around finding ways for the genetic labs and private companies to work together to provide an implementation pathway such that when the decision is made to push this out, we can actually achieve the demand that is going to be really high for managing patients and their prescription going forward. And we need to make sure that pharmacogenomics remains equitable, both regarding future research and implementation, so that all members of our society can gain from the information that it's going to prescribe. And that is where I'm going to stop, and I'll stop sharing at this point. And if anybody wants to ask any questions, please feel free to do so. And you can put those in the chat, or raise your hand if you actually want to talk. Don't mind. Any questions? If not, I don't want to keep you any longer. I'd like to thank you, Venny and Peter and Lara, for being part of this talk. And I hope those of you that weren't able to be here live to ask questions, you'd be very welcome to see this as a recording later. And obviously, we're very happy to help with answering questions as needed. Okay, I will leave you and enjoy your lunch. Bye-bye.